Next, we will hear from Katie Bach and David Cutler. Katie is a non-resident senior fellow at the Brookings Institution, where she writes about long COVID, job quality, and low-wage work. Dr. Cutler is currently the Otto Eckstein Professor of Applied Economics in the Department of Economics at Harvard School of Government. Professor Cutler holds secondary appointments at the Kennedy School of Government and the School of Public Health. We're so grateful to have both of them with us today to talk about the economic burden of long COVID.
Catherine, thank you very much for having us and inviting us. You can hear the fire trucks going by outside. So we're going to do a true tag team here. We're going to pass the baton back and forth a couple of times, although depending on the size of the fire, I may just give the entire thing to Katie. But if we could start off with the slides. Thanks, and then to the next one. There are a couple of things we want to talk about. We'll talk very briefly about the prevalence because that was covered in some of the other presentations. I'll just give you a little bit on that. And then we'll talk about the costs of long COVID. And so we'll do it at two levels. We'll talk about the cost to individuals and families, and then we'll talk about the aggregate social costs. And then finally, we'll come back to the policy choices that influence costs. So if I could jump to the next one, please. So first off, in terms of overall prevalence, as you heard at the beginning of the webinar, this is not known extremely well. There are different estimates from different surveys. There are different estimates in different countries, even with relatively similar acute COVID burdens. In the US, based on recent data from the Household Pulse Survey, asked people, are you currently suffering from symptoms that are long COVID symptoms? About 6.5% of the adult population currently experiences long COVID. That's about 17.5 million adults. Roughly 85% of those, so that's the 5.4%, say that they have any limitations associated with long COVID. And then about 25% of the 6.4% or 1.6% in total have significant limitations. So that's about 4 million adults that have significant limitations from long COVID. That's obviously a really large number of people suffering here. If I could jump to the next slide. If you look a little bit by age relative to the total amount of long COVID, it sort of peaks in the late middle ages. I don't know, maybe I'm getting my own age is coloring my description of this. Roughly 40 to 50 and 50 to 60. It then declines from there, I think in part because COVID was more likely to lead to death at older ages. So the long COVID component is somewhat smaller. Thankfully, at younger ages, the toll is not nearly as big. So you see a sort of hump shape in death, in age. And then on the next slide, shows you a bit by characteristics of the economy. And the long COVID is higher among people with fewer years of education. People without a high school degree, those with a high school or some GED are a little bit lower, but then those without a college degree, without a BA, tend to be higher again. So there's a rough divide in long COVID, as there is with many things now. And the divide is sort of between having a college degree or not having a college degree. And the labor force is working that way. And unfortunately, disease is turning that way as well. So that's a little bit on just kind of how many people have it. As I said, what we're going to do is we're going to turn to what is the net impact both on people and families and then on the economy. So the first thing I'm going to do is I'm going to toss the microphone proverbially to Katie, who's going to pick up from here.
Thanks. Next slide, please. So we're starting with the personal cost, so the cost to patients and to their families. And, I think the first and probably most important thing to say, and this echoes what we've heard before, it echoes what David just said, is the burden does seem disproportionately on people with a high school degree or less. They are likely to be lower income and experience higher levels of financial insecurity to start with. So as we think about the financial impact of long COVID, obviously it depends, as I said, on underlying financial security and on severity, but there are two elements. The first is that patients with long COVID and their households may see their income decline. As has been a theme today, we don't have a definitive answer on the impact of long COVID on work, but we know from the UK's very good Office of National Statistics work that working age long COVID patients are about 35 to 45% more likely to be out of work post-infection than they were pre-infection. We also know from a longitudinal US study that somewhere around a quarter of long COVID patients have either their employment status or their working hours impacted. And obviously both can translate into a loss of income. At the same time that some patients and households are losing income, as we just heard from Dr. Tice, their health costs are rising. Again, we don't have a good number. The best proxy might be what we see in MECFS. As we heard earlier, there are overlaps between some cases of long COVID and MECFS. And in MECFS, we see about $9,000 a year in household spending associated with the illness. Obviously, that is a huge number given the US median income. And as we think about where that number comes from, it's a few things. So one, as Dr. Tice just mentioned, there are no validated treatments for long COVID or these other infection-associated chronic illnesses. And so in many cases, patients are bouncing from doctor to doctor, from treatment to treatment, trying to find something that works and to rule out causes that aren't long COVID. Two, in many cases, people don't have insurance. As we said, this is disproportionately falling on people who are less well off financially. In addition, of course, many people get their insurance through their job. So if you lose your job, you can lose your insurance. And then finally, in some cases, insurance just isn't covering the tests and treatment that some of the more expert physicians who treat long COVID and other infection-associated chronic illnesses are recommending. Final point, I have heard from a number of people who reached out and said, yeah, I don't have long COVID, but my partner, who was not a breadwinner, does. But because my partner was the primary caregiver for the family, I have had to reduce my working hours. And so it's important to remember that a household can lose income even if it isn't the breadwinner who is impacted by long COVID. Next slide, please. So if we zoom out from the patients to what is the net impact on employment, probably the best analysis was done by Gopi Gowda and Evan Soltis from Stanford and MIT. And they found that after a week-long work absence that was due to acute COVID, they looked at what happens to people's labor market behavior after a week-long health absence that was due to acute COVID. And they estimate that somewhere between 500,000 and 750,000 of people have fully dropped out of the labor force as a result of having acute COVID. And that does not include additional reductions in hours worked for people who are still in the labor force after having COVID. There are two caveats as we think about this as a summary of the labor force impact of long COVID. First, not everyone with long COVID took a week off from work when they had acute COVID. In some cases, the acute COVID symptoms weren't severe, and in other cases, they didn't have sick leave and they couldn't afford to take any time off. On the flip side, this doesn't tell us why people drop out of the labor force. It just tells us that many do after having acute COVID. It could be due to long COVID, but it could also be, for example, early retirement and a fear of getting COVID again. So if we can flip to the next slide, I guess the question then is, well, where does that leave us on the labor market impact? And the answer is that we don't have a definitive answer. What we do know is that it is a non-trivial labor market impact, which isn't a surprise given that, as David said earlier, somewhere around 4 million Americans are currently significantly limited by long COVID. I think our best estimate standing here today is that it's probably somewhere between 500,000 and 2 million full-time equivalent workers who are out of the labor force. And when I say full-time equivalent, I don't mean 500,000 to 2 million people. I mean the equivalent of 500,000 to 2 million full-time workers. So that would include people who are still working, but have had to reduce their hours due to COVID. And now I'm going to flip the microphone back.
Okay, thank you. Let me go on to the next slide. So what we've tried to do is add this up to an aggregate cost of long COVID to the economy. And so I want to just give you a brief description of how we did that, and then present the results to you, and then we'll talk about some implications. So at the economy-wide level, there are 3 costs that we consider. The first is the health loss. That is, people are in worse health as a result of COVID. We can measure that in a usual sort of cost-effectiveness manner, which is we know roughly what the disutility associated with having symptoms of long COVID is from other related conditions. And we then value that. This is not money lost. I want to come to that. This is kind of the lost welfare of living less healthy lives, and that's one of the reasons why we try and earn income, is to live better lives. So that's the first part, is the health loss. The second and third are really money that's not earned because people cannot work. That's the second, or money that we have to devote to things other than kind of consumption enjoyment. That's the health spending part. So each of those, if you will, is the loss of GDP, either GDP that's not earned because there are fewer people that are working, or GDP that's not available for consumption of things that we like, assuming we don't particularly like medical care other than that it makes us healthier. And so that's the third of those. Other things that Katie had mentioned that are really important would not show up in a GDP calculation. For example, if you took money from me and gave it to someone else, that doesn't change the GDP of the economy. Makes me worse off and the other person better off, but that's sort of a transfer more than it is an aggregate impact. So as an aggregate economic impact, we want to think about these 3 things here. So we've gone about pricing them out, and I'll show you the estimate on the next slide. Without going into enormous detail, the total cost that I get is around $3.7 trillion. To be clear, what that is that's the cost based on the number of cases of long COVID to date. So assuming that people who have long COVID to date don't do anything different, there are no new cases in the future, and these cases resolve themselves kind of slowly over time in the way that's consistent with literature. So they don't all go on forever, but they don't all end today. And so there are 3 parts to that, the 3 on the previous slide. The biggest one is the reduced quality of life, but there's a very significant, that is roughly $1 trillion impact on earnings that'll occur, and then another $500 billion impact through medical spending, which we benchmark for people with relatively similar chronic fatigue symptoms. I will just note one other macroeconomic point, which is that part of the reason why inflation is high is because firms can't hire workers. Part of the workers they can't hire are particularly low-wage service workers. Remember, those are the same workers that have long COVID, disproportionately have long COVID. And so I actually think part of our current macroeconomic situation now, not all of it, but part of it is a result of long COVID and other things that have reduced the labor force, the labor supply of workers who we desperately need. So I think there's actually even a bigger impact than this, but I haven't tried to quantify that here. In the final 2 minutes or so, we'll just talk about implications. So on the next slide, I'll just give one of them, and then I will pass the microphone back. So first is implications for public policy. One is we desperately need to know more, and this was sort of brought up earlier on by Dr. Koroshet. So we just kind of, the amount that we know about long COVID is just far, far below what we ought to know. There's an interesting part, which is this could have a big impact on SSDI and other forms of disability insurance. So far, we have not seen an increase in SSDI enrollment or applications, which is really quite anomalous. Many workers with long COVID seem to be working. Whether they will be able to continue doing that and what form they will be able to continue doing that is going to depend on all sorts of things, including their own personal health as well as what employers are doing. So there are other sort of implications here. And to talk about those, let me just pass it for the final time back to Katie.
And next slide, please. So when people ask, what do we do to reduce the economic burden of long COVID? I mean, the obvious answer, if you think back to what David presented and where the cash costs are coming from, not the loss of welfare, it's you have to keep people at work. And that means there are significant implications for how employers behave. This matters tremendously to society. Loss of work and income is devastating for individuals and families. It also matters to employers. As David said, particularly when it comes to low-wage service work, employers are still facing significant challenges hiring, which is impacting their bottom line. So employers are highly incentivized to keep people working if they can, which means we need to have better information on what accommodations work for long COVID. A few that we know, telework. Obviously, commuting is tiring, physically demanding, and people with long COVID don't want to risk getting COVID again. flexibility on working hours and deadlines, more frequent breaks, and particularly for low-wage service work, think like food preparation or retail, finding opportunities to let people sit instead of stand if they have orthostatic intolerance. And finally, brain fog is one of the prominent long COVID symptoms. And some workers are finding that prompts are making their jobs easier. So think, for example, printing out recipes for food service workers instead of having them memorize them, or posting checklists. Unfortunately, not all jobs are easily amenable to accommodation. The jobs that are easier to accommodate are jobs like mine that can be done remotely, that are primarily asynchronous. I can work sort of when I want, and that are not particularly physically demanding. The very people, though, who are in the jobs that have to be in person, are synchronous, and are pretty physically demanding, are often lower wage workers. Think retail clerks, nursing aides in nursing homes, and food service workers. So it is critical that we also have a safety net for people whose COVID is too severe and whose jobs just can't accommodate it. Next slide, please. And then finally, the other piece of allowing people to maintain economic productivity and obviously reducing the welfare loss is treatment for people who get long COVID. There are a few clinicians, not many, but a few, who do have experience with infection-associated chronic illness, ME/CFS, which has been mentioned a few times. And anecdotally, though we don't have large-scale trials validating treatment approaches, there are treatments that are helping some long COVID patients. Those who have mast cell activation issues, those who have POTS, as Dr. Gorsuch mentioned, and a few more. What we need are long COVID literate PCPs, primary care physicians, because this is the first point of call for most patients, and specialists who not only understand these conditions and are up to date on the latest treatments, but also critically who take insurance. Today, many of the few really expert clinicians in these fields don't take insurance because the reimbursement model doesn't work for the types of tests, treatments, and appointment times that they are spending. So that was kind of a whirlwind at the end, but thank you so much for the time, and we look forward to what looks like maybe 3 minutes of questions.
Thank you, Katie and David, for sharing your work on the economic burden. We'd